All right, no disclosures. So interestingly enough, arterial endarterectomy as we know it actually started in the 1940s by Dr. DeSantos. He actually performed the first superficial femoral endarterectomy, and he discussed it as amid great confusion, but to my great delight. The patient actually did very well, did restore blood flow to the leg, but he unfortunately expired about 2 days after for renal disease. However, despite that outcome, the procedure actually picked up some steam, and by the 1950s there are multiple case reports about the operation being done throughout the aortic tree, including the aorta. They discussed that this operation may be performed in patients with extensive lesions because it achieves notable improvement in the circulation. However, at the same time, they did notice some complications such as hemorrhage, thrombosis, as well as aneurysm formation. Over the last 50 or some years, the treatment for superficial femoral disease has really changed and moved towards endovascular therapy. The common femoral artery, as well as the profunda, has really been the last holdout for surgical, open surgical therapy. Part of this is due to the fact that it's a really well-tolerated open surgical option with relatively low morbidity, and we'll talk about that in a little bit. But really, the durability of the procedure is hard to argue against. High long-term patency with very low secondary target lesion re-interventions, 90% and plus primary patency, and if you add assisted primary patency, that moves up to almost 100% in 1 to 5 years, with limb salvage rates above 85%. And the majority of the secondary interventions are due to disease above or below the target lesion. With the increases in hybrid procedures, we will also start to see a decrease in secondary interventions. However, and there's always a however with these things, the surgery is probably not completely benign. Perioperative morbidity ranges anywhere between 5 to 21% in the literature. Perioperative mortality, about 1.5 to 3%, and most of these are cardiac or respiratory related. Around 3 to 10% major complications, and these are things that leads to return to the OR, such as hemorrhage or thrombosis. Infection, wound complications, dehiscence, seroma, these usually get lumped into the minor complications, but they're upwards of 8 to 20% in the literature. However, with some of the papers, we do notice that these do cause major morbidity to our patients, especially after discharge and long after the surgery has been done. These risks also increase in patients with COPD, steroid use, diabetes, obesity, renal disease, all of which we see in our patients. So therefore, the question becomes, with increasing technology and with everything else moving towards an endo-first approach, should we treat the common femoral artery or the profunda femoris in the same way? So where are we with treatment of the common femoral artery with endovascular therapy? So mortality and major complications range about 1.6%, which is right on board with endarterectomy. The minor complications, and these are usually access-related like hematoma, pseudoaneurysm, dissection, perforation, and in the cases of using atherectomy, distal embolization. These range anywhere between 5 to 8% within the literature. However, most of these don't need to return to the OR and they're treated conservatively. And since you don't have a surgical wound, you really have no risk of wound breakdown or infection. These patients tend to stay in the hospital a lot shorter than endarterectomy, and the technical success rate is actually quite good. It's over 90% in most of the case series. However, the long-term outcomes is really where we kind of lose the narrative. Restenosis rates of 20 to 30%, target lesion revascularization around 20%, primary patency runs somewhere around 80%, 82%. In some papers, they've quoted 87% at just 6 months and 77% in 1 year. Question of whether or not to stent is a huge controversy about what type of stent to use, when and where. Some groups have found that using stents routinely versus selectively increases your primary patency rate. However, that also increases your stent fracture rate. The vascular VQI looked at this and found that stent use was actually an independent risk factor for reintervention and amputation. So really, where does this leave us? I think right now, if you ask me, I think common femoral endarterectomy remains the gold standard. It's a very durable procedure with very low risk. However, as I think for surgeons, we need to recognize that some of these what we deem as minor complications do cause significant morbidity to our patients in the long run. I think patient selection is going to be key. Is this the right therapy for the right patient? A patient who's 50 without significant comorbid conditions is going to be treated differently than your 90-year-old with a 3-time redo groin. And which lesions are more amenable? We see this in patients when we talk about carotid stenting. A smooth tapering lesion is going to be treated differently than a heavily calcified lesion. The goal should always be to preserve the common femoral anatomy. To preserve profunda flow is really what we're talking about. Angioplasty, use a balloon that's matched to the native vessel or smaller. If a stent is needed, the lowest number needed to treat, bare metal self-expanding stents seem to do a little bit better in our current literature. Debulking with atherectomy as well as drug-eluting balloons seem to suggest some increased patency and durability, but this isn't definitive by any means. And we need to remember that medical management is important. Antiplatelet therapy, statin therapy, smoking cessation should all be broached with the patient. And really what the data currently shows is that with endovascular therapy, we need these patients to be followed up. About 20 to 30% will need some additional treatment in the future, and we really need more data on the matter. Thank you.